Before you start into your presentation, if you could remember, what was your first impression? When was the first time you saw the NASG, and what was your reaction the first time you saw it?
We saw when Dr. Burke had come. So Dr. Thomas Burke was
Mm-hmm.
one of the pioneers for doing this PPH bundle study on
Mm-hmm.
emergency management,
Mm-hmm.
along with Dr. Yarkar and Dr. Andre also was involved in this study.
Wonderful. And what was your thought the first time you saw it? What did you think?
The moment we saw that, we had a good idea about, how people, they use certain stockings and all to
Mm-hmm.
ensure that the blood goes to the vital organs. So when we saw that, it was a very simple technique, the way you wash it, the way you clean it, the way you put it, and the training was not really so difficult. So we said that this is going to work in our lower settings because I belong from a rural area. We are rural obstetrician. And so we thought that, yes, this is something which we need in our PPH bundle as a mechanical device. So this is
Wonderful.
how we started.
That's wonderful. I'm glad to hear it. So please go ahead with your presentation, and we're so happy. Thank you so much.
Thank you, Michelle, for giving me this opportunity. It's my honor to present in front of people who have done a lot of work globally on this particular anti-shock garment. So what I am going to present to you mainly is non-pneumatic anti-shock garment in obstetric hemorrhage, and I'm going to talk to you about MGIMS experience. When we talk about MGIMS, this is a very special institute started by Mahatma Gandhi, and this is a nodal center now, National Nodal Center for Midwifery Training as well. Now, this is an institute which follows all ethics and ensures that all our trainees they have some kind of rural bias and they understand that rural obstetrics is very different. My session objectives are to understand a bit about NASG, which I think I will skip because each one of us know about it. To identify the correlation of NASG with obstetric hemorrhage, what is the Indian experience, literature recommendation, what are our national studies, and then what is the Sevagram statistics of NASG and a bit of echo messages. So we all know that this is a very unique device of low technology and it is designed as a first aid device to treat hypovolumic shock in hemorrhage. Now, we all understand what are the various indications, but here there are some indications which in rural area are very, very peculiar. PPH, we all know that it is one indication, but here we have seen that antepartum hemorrhage, especially due to abruption and placenta previa, some or the other way this NASG has helped us. Here, I particularly wanted to talk to you because we say in the literature also it is said that if you have a viable fetus, then you know you should not use NASG. But we particularly want to talk about two cases, which were one was abruptio placenta and another was placenta previa, and they were pulseless and BP-less. We just tied the NASG garment, shifted them to OT, and by the time everybody came and we started resuscitating the patient, the pulse had come back, the blood pressure became 80 by 50. So the one who was without any pulse and blood pressure certainly became slightly better when you talk in terms of applying NASG, shifting the patient to operation theatre. So this is where I differ from these contraindications which have been mentioned in the literature. Now, this is our study, PPH emergency response study, where I would like to, talk about three stalwarts. One was, of course, Dr. Thomas Burke, who said that he's going to do this study with us, and we did it in 10 medical colleges from Maharashtra as well as Madhya Pradesh. Then, of course, Dr. Yarkar, who was always with us, and Dr. Andre, who was with us while we were doing these studies. So this was a very small card which was created and in which you can see NASG garment is one of the very major part of refracted PPH. intervention. There are several global study. One of the systematic review is there, but I'm going to talk about India. And when we talk about Indian studies, these are sporadic and they are not randomized controlled trial. So there's a hesitation of the government of India to bring it as a central policy. However, there are states who have been using it. There is a lot of data available from Tamil Nadu, Andhra Pradesh, and now we are taking it to UP, Jharkhand, Maharashtra, MP, Chhattisgarh through Safe Motherhood Committee, where Dr. Preeti is one of the major person who has really spread it over as PPH bundle. These are some Indian studies which we come across, but there is a problem here. Especially, you see, the Miller madam had done this particular study in Tamil Nadu. But problem is that again, they expect RCT. Now, being from rural area, how do you expect that to one woman I will give, which is a treatment and which can save her from death? And on the other side, we will not give to the women when we know that this can help. So doing RCT, we feel that it is very unethical, and that is why we could not really do it. There was a very major trial done, Boost trial in UPTSU in UP, which was funded by Gates Foundation. But again, it was not accepted by Government of India because it was not an RCT. Coming on to the MGIMS experience, the 10 medical colleges, they began with UBT and then we went on to PPH bundle. And in this bundle, we had non-technical and technical components. In the technical components, NASG was a major part. But we certainly looked into non-technical component because how much good your hospital is, how much devices you have. If the women does not reach to you, then there is no question of doing all those exercises. So we did workshops in 10 centers, trained A&M, ASHAs, everybody. Before sending, they must tie the NASG we gave. And the training is very easy. So we did the capacity building and some very interesting cases came. If you can see, these are the training modules which we did, and then we ensure that our ASHA and A&Ms are given some importance so that they do better in sending the PPH patients to us. So these are some, slides which we are showing. And you see, we created a WhatsApp group and we did training in 26 PHC, 9 rural hospital, 1 district hospital, trained all the staff, and then they shared the stories. And these are some very interesting success stories where all these women, they came in shock. And the last one where the twin is there, this was done when there was a very big meeting Dr. Burke has conducted here, and all the stalwarts were here. And in front of them, this woman bled, and we could manage her by using only PPH bundle card using NASG. Some of the women we used UBT as well. So these are some interesting stories. The last one is of our own nurse, whom we have saved from grade 3 shock. So we did this system integration where we had helplines, and the women did not have to go from PHC to CHC, then district hospital, and then come to the medical college. These helplines were so helpful that the even ASHA and ANM could call in the labor room, and our team was ready to save the women. We immediately shifted the patient to the triage area and then HDU, and we could do all the procedures. Each place where we did this training, we went nearly 4 to 5 times to ensure that each one of them is trained, and our postgraduates and consultant, they stayed there. And we ensured that everyone is trained so that we get the best results out of it and we save all the women. We did a lot of advocacy branding. We did PPH walkathon, which was very liked by we gave radio talks, which was liked by the government. And so government of Maharashtra allowed us to do certain at certain places and create an evidence. Now, the success story was this, that the maternal mortality due to PPH was reduced for nearly 1 year, 9 months before having COVID. In the COVID, then we had some different issues because of which 3 deaths were there in the district. Morbidity due to PPH reduced very significantly, 79.6%, and 52% of the women came with NASG on after training. 46% of referral came with UPT on. Helpline calls were as high as 89%. And out of those, 29% we shifted directly to OT. There were some issues. One was the human resource because people were very resistant, and it was difficult to train old ANMs and ASHAs because they had some different ideas. But we repeatedly went there. We showed them videos and all, and then we could really help them. The training was zero for them. They had no idea about these devices. We ensured that they learn and they also know how to put it. And then we tried to bring it in the system, and we distributed an ASG, which was given to us by some foundations. Now, then we went to UP. We went to UPTSU to know how they did the study. We went to KGMU Lucknow, Varanasi, and we took 10 centers there. And there also we started this, and now everyone is using them. So 2.5 years, this kind of a study was there, where our technical partners were FIGO, MGH, Harvard, MGIMS, Sevagram, and of course we had technical partner like Dr. Yerker, Dr. Andre, and of course Dr. Bhatt. So we did lot of planning. Phase 1, we did basic assessment, selection of the site. Phase 2, we started training medical college. Phase 3, we started with district hospital, CNCs, PNC. Then we brought up a manual, PPH EMC manual, which is actually brought up by Dr. Thomas Burke as Thinkific module because COVID was there and we could not go personally. But this particular module, where NASG is one of the major part, was also appreciated by everybody. And stakeholders accepted it excellently, but you will see that the FOXY guidelines in India, they have taken it, and even FIGO has considered bundle approach using these NASG as one of the major part. And Jeevan Dhara project, which is going on through Safe Motherhood Committee, which was led by Dr. Preeti, is really working wonderfully. And these are some pictures which I wanted to show you. These are some pictures. And this is our team which had gone to give trainings to each place. Now, this is the statistics of MGIMS. You can see how many women reported with NASG on. We had, out of all these, 56% were referred cases during transport and using that NASG garment. And this NASG garment was put in by trained staff. We did have 3 deaths, but they were into irreversible shock. By the time they reach here, they were either in DIC or in the renal failure, where their creatinine was as high as 14, 15. So those 3 we could not save. And this is our model. By these methods, system integration, facility readiness, continuous quality improvement, teamwork and communication, and of course, advocacy, we have brought down our maternal mortality due to PPH so significantly. So 2018, we had 0 PPH death, but now there is slight COVID, we had a bit of death. In 2023, we had few cases which were actually due to the insistence of the women not coming to the hospital. So these were home deliveries, although very less home deliveries are there in Maharashtra. But there's an area called Melghat where, the women do not let those are tribal women, they do not let the doctors come in. So the traditional workers who are there, they are not really well versed. So now we have opened our own MCH wing there, and we are planning to go and teach those women, taking them into confidence that they could be the ones who can reduce maternal mortality. With that, I thank you so much for your patient hearing. Any questions, I would be very happy to answer. Thank you very much.